Nice. Welcome, everyone. It is the top of the hour to season 5, episode 226, where we'll have a feature presentation on South Dakota's creative solutions to increase access and care to 988. So, super excited. My name is Laura Evans. I'm the AVP of Public Policy and Government Affairs within Vibrant Emotional Health. And thank you for joining us for the next hour on this jam. Some housekeeping rules. Really, there is only one thing you shouldn't do, but let's focus on what you should do. Let's focus on having your platform in speaker view instead of gallery view. That'll give you the best chance to see the speaker and their slides. Make sure you're joining in, whether that's through the hot seat question or sharing your thoughts, comments, questions in the chat. But remember to be on mute unless you are speaking. And if you'd like to speak and you're in the audience, please send a message through the chat. And if there's time, we'll try to open up your line, but we really want to make sure that we get to our amazing featured presenters today. So hang in there, participate with us. And if you'd like to use the new ASL feature so that you can have the interpreter at the top of your screen, make sure you go to the bottom right, click more on your Zoom, and that will give you the option for sign language interpretation. So that is available to make sure that the Zoom is accessible to everyone. But as I mentioned in the green room, we are celebrating today. Today is the 3-year anniversary of the transition from 10 digits to a 3-digit 988 Suicide and Crisis Lifeline. So very excited. July 16, 2022 was the official go live date so that everyone in the US or on US military bases could dial 988, text 988, and they would reach a trained crisis counselor. So happy birthday, toddler status, but we have done a lot in these 3 years and the time getting up to the 3 years. But we're going to take a look back. And on Go Live, this is one of the highest watched, viewed, participated crisis jams. We had Dr. Marian Delphin-Rittman, who was at the time the head of SAMHSA, the Substance Abuse and Mental Health Services Administration. And it was an amazing jam session, right? Talking through the possibilities. And of course, David was our host for that. And what the conversation was, what a major thread there was, this is the beginning, right? This is the beginning of the race, and it is a marathon, not a sprint. But really, just having a 3-digit number that folks can remember when they're in crisis, to connect to trained crisis counselors is really the start. Now we need to make sure that we are connecting the rest of the continuum, that we are ensuring that people are preparing and are aware. Just the beginning. And even 3 years down the line, we still are maybe closer to the start than we are to the finish. But it's just amazing to see the progress that has been done. So on that look back, we also had Representative Steve Elison, who's maybe the father of a 3-digit number because he originally had the idea for a 3-digit number to the Lifeline back in Utah and was then told that, hey, that's not a state issue, that's a federal issue. Did not let that deter him. He took it to the federal government, to Capitol Hill, and here we are now. You'll see here, this was a great interview with Stephanie Hepburn, a photo of John Draper and Steve there. So where are we on the jam after 5 years and entering season 6 in September? We're at 575 unique speakers. So we are adding 5 new speakers today, including our featured presenters and our crisis talk topic. So very excited. If you do not see your name here, let us know. Either if you were a speaker and you're not on here, let us know, or if you don't see your name on here and you want to be a speaker, let us know, because we want to hear from you what your topic is, what is happening in your community, your perspective. We need it all if we are going to have the crisis continuum that we need. So thank you to all of our speakers, and especially the 5 who are joining that list today. You can see all this information on talk.crisisnow.com. This is the website where you can go to the learning community, You can watch the jam live through YouTube streaming on that site. There, you can register for the jam. You can get the virtual backgrounds. You can see the past materials. Everything you want is in this one-stop shop, talk.crisisnoun.com. And again, you can see all this on YouTube as well, not only live, but then you can go back and there's a little cheat sheet here that I like to use myself, is that they are color coded. So the debates are in neons, fireside chats in orange, featured presenters like today will be in yellow, highlighted there, live and locations on blue, day in the life in green. So if you have an idea or what an idea of what you're looking for, you can search by color as well. But make sure you like and subscribe so you never miss a video. All right, and we're wrapping up our debates on season 5. We've had some really great, interesting debates this season. Our last debate is should states prioritize building capacity in the 3 core crisis services? We have Paul Gladys, who will be arguing the affirmative, and then Dr. Joe Parks on the opposite end. That will be August 27th. And every debate I have seen has just been really thought provoking. And when I think that, oh, I'm going to land on one side, I sometimes end up on the other. So looking ahead, we've got debate 10, coordinating follow-up care and crisis services requires high-tech software solutions or maybe low-tech. We've got our very own David Covington taking the affirmative and Dr. Jessica Pollard taking the opposite, taking the negative. So all right, as we look ahead, we've got season 6, Crisis Jam Unplugged. More to come on that, just giving you guys a little teaser, but September 17th, we will be sharing more information about that. So thank you for sticking with us through all of these seasons. Now for a little bit of news. First up, a new NAMI Ipsos poll around awareness for the 3rd anniversary for 988 Lifeline. Again, seeing an increase of people now aware. Before it was about 25%. But let me see if there's anyone from NAMI here that can speak to this. Stephanie or Hannah, are you in the room?
Yeah, Laura. Hi, it's Stephanie. So I'm happy to speak to this a little bit. Thank you so much for highlighting it. And I will actually post this in the chat as well. Yeah, so at NAMI, to help mark the 3-year anniversary, we released a new edition of our public opinion poll on 988. Just some key findings that you can see here. Actually, I'll start with the awareness. So awareness of 988 is at an all-time high, with 74% of Americans having at least heard of 988. That's dramatically up from the 44% that we first got when we first did our poll a few months after 988 launched in 2022. Here you see actually another measure, familiarity, slightly different than awareness. Familiarity means not only have they heard of 988, but they have some understanding of what it is. And you can actually see that then in the yellow line, and you can kind of see that there's quite a gap between awareness and familiarity. We've got 28% of people who would describe themselves as being familiar with 988. And so that's really a gap that is an opportunity, I think, that we should look at too.
Awesome. Well, thank you.
Yeah.
Oh, go ahead.
Oh, yeah. Did you want me to highlight anything else, Laura, or was that the main thing? I can run through a few more findings if you'd like me to.
Yeah, maybe just one or two.
Sure. So interestingly, kind of following up on that education gap, we found only 1 in 10 Americans currently knew that 988 is still funded by the federal government. And so I think that's a bit of an action item for all of us here to reinforce that 988 is still available and a resource to them. We also saw a lot of support for the continuation of resources focused for youth and young adults. We know more people are reaching out to 988. We got about 1 in 10 people said that they had contacted it. And really encouragingly, most people said that they're getting the help that they need. 71% indicated that they got the help that they needed. And also that basically policymakers have the public support for crisis systems. 86% of Americans thought the funding for 988 should be a high priority for Congress. And then at the state level, 82% of people wanted to see that be a high priority for their state lawmakers as well.
Awesome. Thank you, Stephanie. Appreciate the work from NAMI to highlight the importance of the 988 Lifeline and ensuring that it is robustly funded. Also released this week, I believe it was Monday or Tuesday, the Kaiser Family Foundation released information on demand for 988 as we look at the 3-year anniversary. And this slide you'll see here, or image, utilizes the Lifeline data set that's available publicly. And so you'll see here over 16 million calls, chats, and texts received since that launch. Bringing it down by calls, chats, and texts. Again, calls is sort of the legacy, but chat and text are newer modalities that have been added, and we have since added video phone for folks who are deaf and hard of hearing. But again, as Stephanie mentioned, it's most important that folks are getting the help that they need. Oh, thank you for sharing that, Dean. We'd love to see that. So taking us back very quickly, back in before launch, we were looking at the entire universe of what are the possibilities of calls that could come into the 988 Lifeline. And so at that time, it's about 5 million contacts, calls, chats, and texts for the Lifeline. And then if we took a look at, okay, what are the local county state lines that existed, anticipating about 13 to 20 to 15 million contacts. And then for contacts that are going to 911, conservatively estimating about 10% of the calls that come into 911 are more appropriate for 988, and that was about 24 million. So at that time, the potential 1-year volume was 40 million annual in calls and contacts to the line. So I think that's the power of 3 digits, right? Going from 1-800-273-TALK, which is hard to remember, to 988. So let's look at our counterparts. When 911 was introduced, it effectively cannibalized call volume from hundreds of local 10-digit numbers for emergency services. What is the name for the strategic process in telecommunications and service design, right? So again, what is it officially called in the telecommunications space when you have a 3-digit number that will replace a lot of the 10-digit numbers that folks were utilizing? Is that call diversion, number cannibalization, service consolidation, or demand fragmentation? Make sure you fill out that poll that just popped up. If you want to put some thoughts in the chat, welcome to. If anyone feels particularly brave, happy to open a line if you raise your hand. Have we stumped you all? All right, it looks like the audience might be split. Can we open Barbara's line for just a second? Oh, Barbara, we may not be able to get back to you. I'm sorry. Oh,
it's okay.
So we've got 54% of the audience saying service consolidation, 27% call diversion. And it looks like we've got most of you here. Service consolidation is the correct answer. So if you do want to get in the hot seat, t-shirts are coming back. Really great swag. Reach out and let us know. But the official name for this is service consolidation because it is still the service, emergency service. Instead of having multiple 10-digit local numbers, there is now one number that folks can call. So they consider that service consolidation. So with that, I'm going to turn it over to our wonderful colleagues in South Dakota, Janet Kittams and, Jordan Mounga, who represent the South Dakota Department of Social Services Division of Behavioral Health. So I'll turn it over to you ladies.
All right, thank you, Laura. Jordan and I are very happy to be here today with you to kind of tell you what's going on in South Dakota. So if we go to the next slide, we just want to kind of set the stage for what the state of South Dakota is like. So we're a large state territory wise. We have over 77,000 square miles, but we have less than 1 million people who live in South Dakota. So we have a lot of rural, a lot of frontier areas, a lot of sparsely populated areas in the state. And we're also home to 9 tribal reservations in the state. So our next slide talks just a little bit about how 988 operates in the state of South Dakota. So it's answered by a single contact center, which is the Helpline Center, which is where I work. And we staff 988 with mental health counselors with advanced degrees. 988 is a partnership from the very beginning between the Helpline Center and the South Dakota Department of Social Services Division of Behavioral Health. We worked on planning the 988 implementation together and continue to look at how we can implement even more and market 988 across the state. The Helpline Center established some MOUs right away when we launched 988 with our 911 PSAP centers across the state, really to encourage and facilitate that transfer of behavioral health calls that would be better handled by the 988 counselors. And that's been a wonderful partnership, and we'll hear more about that a little bit later. So the Helpline Center also partners with several Native American organizations in the state to increase awareness about 988 for that population. And then we also to increase the awareness and cultural competence of Native American issues with our 988 counselors. In addition to answering 988 for the state, the Helpline Center also answers the 211 phone number, which is more basic needs, information, and referral, but they do receive mental health phone calls on that line. So because we're co-located, it allows for that seamless transfer from a call on 211 over to the 988 counselors if there's a behavioral health issue. And then our next slide is going to talk a little bit more about the data for 988 in South Dakota. So we have a data dashboard on the Helpline Center website. We update that on a monthly basis, just allowing people to be transparent with the data that we have. You can search by very specific communities across the state, by counties, or if you want to look at data statewide. So what we put up here today is just our data that from the start of 988 back on July 16th in 2022 through the end of May. So we're excited that our contact volume has tripled since that first month to today. So we've seen a lot of interest and people that are wanting to reach out for help. So 31% of our contacts over that time frame have been more focused on support and information, but 31% were crisis related. Most common presenting concerns included suicide, anxiety, those relationship family issues, and depression. So we have reached all 66 counties across the state with contacts from calls, texts, and chats from 988. And about 97% of our calls we stabilize without having to use any type of law enforcement intervention. All right, and then our next slide is going to talk a little bit more about how we marketed or how we are currently marketing 988 in South Dakota. Because we're a rural-based state, we knew we had different segments of our population we wanted to educate about 988. So we did include some very specific tribal community marketing, and you can see one of those marketing efforts at the top there. And then we also tried to target our farming and ranch community across the state. And so there's a picture that's depicted there. And then also with the rodeos that happen across the state, there's a campaign that's called the Yellow Feather Pickup Man campaign. And if you're not familiar with that, it's just a wonderful way. If you don't know what a pickup man is in a rodeo, they really are the support person and the lifesaver really in a rodeo type of situation. So we promote that at all the rodeos, professional and the high school based rodeos. And then the next slide shows just a little bit more of our marketing efforts. So one of the decisions we made right away, excuse me, with marketing 988 was we wanted to get it into the hands of people as soon as we could. So we made the decision to make all of the marketing materials free and people could just simply request those. So on our website, they fill out a simple form. They request magnets, posters, cards, stickers, whatever it is that they need to market 988. And so we have literally filled thousands and thousands of orders for people requesting 988 materials. And sometimes that's from an individual, sometimes it's a business, sometimes it's a nonprofit organization, but they all want to help to get the word out about 988 in South Dakota. So that's been a very successful marketing effort on our part. And then the next slide talks about what's new at 988 in South Dakota. So we launched a peer support program here just in March. So really, really new for us. But that peer support program really helps people who have those chronic mental health or substance use struggles. And we're working with them towards that recovery. So we operate that program from 10 a.m. to 10 p.m. every day. And all the referrals to that program come directly from 988. So our counselors kind of assess when somebody calls, texts, or chats into our 988 system and determines if they would be best served by a peer support specialist. And if that's the case, they make a referral over to the peer support specialist. They take the call right away if they're available. If they're not, they fill out a form, and then the peer support specialist makes that call back as soon as they're available. So far, we've seen typical presenting concerns, including anxiety, depression, family issues, and just very positive response from the individuals that we have sent over to the peer support program, and a lot of positive response from our 988 counselors. They really feel like that peer support program offers an additional support system for those individuals that may have more chronic mental health or substance use struggles. So we're excited to see where this will go since it's just so new for us, but so far so good. And with that, that is 988 in South Dakota, and I'm going to turn it over to Jordan to talk about other crisis response in the state.
Thank you so much, Janet. My role within the Department of Social Services and the Division of Behavioral Health, I serve as the program manager for suicide prevention and crisis services. So the three pillars of crisis care being under our team. And so we are so grateful to the Helpline Center and Janet and her staff's work with the implementation of 988 and all that they do. I'll be speaking on the two other pillars of crisis care and our mobile and virtual crisis. In South Dakota, we have two community mental health centers across our state, as Janet had shared. We are very rural and often referred to as frontier. And so we do have some mobile crisis teams in two areas of the state. One in our Sioux Falls region, which is the most populous. And that is in the southeast corner that is run by a community mental health center where they have a co-responder model with law enforcement. And then also in the central region of our state through Capital Area Counseling and their community mental health center, as well in the Pierre area, which is actually our capital. We also have, for those that do not have access to mobile crisis teams, we do have in 35 of our counties and or their police departments, they do have access to virtual crisis care through a partner that we contract with called Avel eCare. This gives the departments access to tablet technology and access to bring your own device. So if they have a department cell phone, that they would receive a link that they would have 24/7 access to virtual crisis care to be able to try to de-escalate and stabilize an individual in their home, as in those areas across our state, in those very rural and frontier areas, law enforcement are often going to be the first that are going to respond. So being able to equip them with the equipment that they need. Our next slide shows the the amount of coverage across the state. Those in green are the ones that are currently utilizing our virtual crisis care. The ones that you see in tan are have the mobile crisis teams. And then those in gray are either utilizing services through 988 to be able to call, or they are utilizing something through their community mental health centers. All of our community mental health centers and crisis care, we do highly encourage them to have the individuals that they come in contact with utilize 988 in the future. So within our third area of the Crisis Now model and our short-term crisis services, we have made sure that we have our state split into 5 regions, and we are wanting to ensure that we have an appropriate regional facility within each of those 5 areas, within them, to be able to have short-term crisis services. So within 5 days or less of being able to keep people close to home and close to their services and their loved ones. So within those, then we do have currently 4 short-term crisis services, and you'll hear from one of the CEOs of one of those during our roundtable. But we do have one in our most western region. We do have one that is in our northeast area. We do have one that is 2 actually that are within the blue area that you see, and actually today, where it says up to 14 beds, they are actually having their open house and opening up those 14 beds to expand from the 8. We are currently still in the stage that we are trying to find access and services within our central region. They're in the green, but have been able to, with some grant funding, be able to provide some transportation to those counties within the central region to be able to access the services in other areas. Throughout the state, we also have 4 inpatient behavioral health units as well. And then there is within Sioux Falls, there is a 24-hour or less crisis stabilization center called the Link that will also serve individuals within the community. So with that, I will turn it back for there to be the roundtable and any questions.
Awesome. Thank you, Janet and Jordan. Great presentation, lots of questions and comments in the chat. So we're going to bring in Amy Chase, who's the Metro Manager of Communications for 911. And then we have another Amy joining us. And so for this roundtable, I'll actually turn it back to you all to ask some questions.
Thank you, Laura. Well, I'll start with the first Amy. So Amy was one of our first partners with the 911 PSAP to work with 988. So maybe Amy, you can just talk about like how that has transformed the services that the 911 staff provide.
Yeah, I mean, right from the get-go, this was an exciting opportunity that we had, and Janet and I really had the opportunity over the years and different positions that we've held to kind of have these discussions before even 988 was even a thought. So really exciting once it rolled out. It really allowed all of us to focus on putting the right work in the right place. And historically, 911 was just the easy option for people. And when you called 911, you got a law enforcement response. But as we all know, law enforcement response is not always appropriate and sometimes can make the situation worse. So it's been a really exciting opportunity over the last 3 years, and we've seen tremendous impact.
Yes, absolutely. I think both of our staffs have worked well together, transferring calls as needed back and forth. So, Amy, if we were to look at the improving the system even more, any thoughts on gaps we could fill in?
Yeah, I mean, I think anytime you can continue to expand that partnership even beyond what we're doing now, and Janet and I, we've had the opportunity to talk about some of those pie in the sky ideas, like what more can we do? But I think it goes back to, again, making sure that we connect the people and the community truly to the resources they need. Do they need law enforcement? Do they need immediate intervention where my staff, we operate in call taking where it maybe is a minute and a half, 2 minute, 3 minute phone conversation? Or do they need more interventions from the staff at 988 where they can provide that long-term and follow-up care as well?
Yes. Thank you, Amy. It's been a great partnership. Looking forward to having it even be a longer partnership. With that, I'm going to turn it back to Jordan, and she's going to have a conversation with our other Amy.
Thank you, Janet. I'll introduce Amy Iverson as the CEO of West River Mental Health Services and the Short-Term Crisis Center Pivot Point in Rapid City, South Dakota. I'm going to ask Amy to share with us her experience of being a part of the behavioral health system that did the launch of behavioral health crisis care services in the state, and being a part of that work group, and her experience of that expansion, and now the services that are provided through Pivot Point.
Yeah, thanks, Jordan. So yeah, I've been involved in this for many, many years, actually. Starting in state government when we first started looking at the need for regional crisis services due to the pressure that was being placed on the state psychiatric hospital, which we have one of in South Dakota on the southeastern side of the state, and just the need for that crisis care closer to home so people weren't having to end up at a state psychiatric hospital for what turned out to be very short lengths of stay. And so did some work initially when I was with state government to set the stage for the possibility of having short-term crisis services on a regional basis, run privately, some changes to our state laws to allow those centers to be able to not only take voluntary folks, but also to take people on a mental health hold, because that sometimes happens where people end up on a mental health hold, and at that time would either end up quickly going to the state hospital or sometimes staying in jail for a short period of time to be assessed before they could get to the hospital. So not a good system for folks in a mental health crisis at all. And so we really started working on developing set the stage for the development of those services, looking for funding, starting a small pilot, and then fast forward several years. And I am then running the agency I run now out in Western South Dakota, Community Mental Health Center, serving the Western third of South Dakota. And as I came here, was able to open the crisis stabilization service that we have here called Pivot Point. And so we're able to provide those short-term crisis stabilization assessment and then stabilization services for folks here in Western South Dakota, and keep them on the western side of the state versus having them go to the state hospital. So just to give you an idea of kind of the numbers and kind of what we served almost 1,500 individuals during calendar year 2024. About 750 of those went into a bed in our facility. The rest were worked with over the course of a few hours, less than a day, and then transferred back into the community with ongoing services. But about 750 went to a bed, and only 31 of those needed higher levels of psychiatric care. The rest we were able to stabilize or get to other services if their needs weren't for mental health, for example, addiction treatment. So we really feel it's been successful in serving folks locally and stabilizing crises without having to escalate it to the point of law enforcement involvement, inpatient hospitalization, those kinds of things.
Excellent. Thanks, Amy. Would you share, like, in your opinion, what is South Dakota still like our biggest need in our crisis care?
Well, you said it, Jordan, when you were talking about kind of the services that we have, and it's those areas in the central part of the state where we don't have crisis stabilization services. There's work to try to develop that, but they're expensive service to run, and you need some volume to make that financially work, or you need to attach it to other inpatient type treatment so you can share staff and resources, and that's just lacking in the central part of the state. So I think that's a significant gap still.
Thank you, Amy. Anything additional that you'd like to add?
Well, if I could jump in, I know there's a lot of questions in the chat. If you all could take some of those. I know, Jordan, you've been jumping in there, but great questions in the chat related to peers and Native American populations. So just appreciate all of you, Amy, Jordan, and Janet, for highlighting what's happening in South Dakota. And I think it's something that other states can look to, particularly who may have similar geography challenges. Awesome. Okay, well, let's move forward to the next segment of the jam today, and that will be an update from the grandfather of crisis. We're being joined by Dr. Richard McKeon from SAMHSA. Richard, over to you.
Thank you, Laura. Pleasure to be here today on the 3-year anniversary of the launch of 988, when 988 became universally available on every cell phone, landline, and voice over internet device. So it has been an incredible 3 years. We are so grateful for the support of 988 that has been received. But probably more than anything else, we want to thank the workforce of all the dedicated professionals or volunteers who have been answering the calls, the chats, and the texts. At the National Suicide Prevention Lifeline, for years, we always had to rely heavily on the sense of mission and dedication of the responders in those call centers. And 988 could not have been successful without their incredible work. So hats off to all of the workers in all of the 988 centers, and of course in other crisis facilities and programs as well. Also wanted to mention that yesterday, SAMHSA newsletter acknowledged the 3-year anniversary and also included a number of testimonials from people who had used 988. And so I would call your attention to that. When we worked on the Hotline Designation Act prior, to the Hotline Designation Act, had SAMHSA, the VA, and the FCC all do reports. And in SAMHSA's report to the FCC, we expressed the hope that a 3-digit number, we didn't know then it would be 988, could play a transformative role in behavioral health crisis services in the United States in much the same way that over half a century, 911 played a transformative role in emergency medical services. And it's been amazing to see the extent to which that's happened, that is the road that we have been on and will continue to be on. We had also in our report under the Hotline Designation Act, indicated that we thought that a 3-digit number would be superior because in the middle of a suicidal crisis, it was unlikely that somebody would remember a 10-digit number, but they could remember a 3-digit number. In much the same way that if somebody is experiencing a medical crisis, that both a person and a family member are going to remember the number 911. but we were concerned in a suicidal or other behavioral health crisis, they wouldn't remember 1-800-273-8255. And the FCC, in their report to the Congress recommending the establishment of 988, quoted from what we had said in our report to the FCC. Just a number of other quick things. Tomorrow, the Crisis TTAC that SAMHSA funds will be having a webinar on resiliency building for vicarious trauma. So if you feel free to register for that. And next week, the Center for Mental Health Services at SAMHSA is putting on a policy academy focused on 6 rural certified community behavioral health clinics focusing on their crisis systems. So crisis systems, rural areas, and CCBHCs, obviously very relevant to our wonderful presentation today about South Dakota. So I will stop there and thank you for the opportunity.
Thank you. And thank you, Richard. You're getting some love in the chat. We would be remiss if we didn't acknowledge your role in this, and everyone at SAMHSA who has guided the Lifeline program from back in 2004 and to now. So just thank you for all of your work. Now I'll turn it over to Dr. Kelly Posner. Hopefully I got your last name correct, and apologies if I did not, for an update related to the states. And you may be muted.
No, I'm not. We're just, oh, there we go. Okay. So, hi, everybody. So, I wanted to give an update first, starting with the data on the improved crisis response and care delivery impact. You know that the Columbia is policy across states, across systems of care, and the impact it's having in these very vital days is the following. It's reduced the level of force among police. Every policeman in Connecticut has that little sticky pad because they don't have to go fight with people to take them to the hospital that don't need to go to the hospital. And this is all over the world. The crisis response team in Singapore reduces ED visits. When EMTs use it, it increased voluntary hospitalization by 66%. And there across the states, there's this great coordination with 988. So people use the Columbia to bring, you can see this one example, 98% of the time they were brought to a place of safety within the call. And the legislative efforts actually document that. And in the legislative efforts, you can see this is Connecticut in schools. You know, these kids who are sit in ERs for hours and hours who are not at imminent risk and would be better served by community resources. Next slide, please. And you know that this is examples of many, reducing hospitalizations, saving millions of dollars. And I always say it's not about the millions of dollars, it's about all the harm that gets avoided. And this is so critical in this time of cuts where we need to deliver better care. Next slide. And I really want a very important update is on workforce prevention. So, you know, there's a Columbia Protocol app, and Department of Homeland Security were the first ones to customize that. So it asks you what component you are, then it goes to their EAPs. And it doesn't matter what workforce you are, if you're a professor at a university or the state of Virginia in corrections or NYPD, and look at the outcomes. This is one example. So ICE, for example, has not had a suicide in 2.5 years since the Columbia Protocol app, and they merge it with peer training. Next slide. And this is really important. This is Colorado youth, but it's mimicked across every state. 80% of them take their lives at home. So how do we leverage technology? We do that. How do we get in every home? We do it with the app. And across all 50 states now, it will connect a person, a youth, a veteran to their local resource based on geolocation. And that couldn't be more important. And it's mining data for systems and communities. Next slide. And this is really important. You know, there was a big meta-analysis, 67 studies that showed what we know. The majority of people who die by suicide have never gotten close to a doctor. So how do we get upstream public health? So this is an example, one example of what New York does. Every state agency, you know, transportation, DMV, agriculture, et cetera. In a number of states now, every veteran disability claim filing. This is how we save lives upstream and routinely. And the very big importance of actually, you know, going in non-traditional places. This is an example in dentists all over. And again, with DHS, 27% of people that were being served were not mental health, you know, visits. So without doing this in all these non-traditional places, you can't do what you need to do. And, you know, bars and casinos and et cetera, et cetera. So next slide, please. And then finally, you know, one of the big barriers was malpractice concerns, liability. So the Columbia has really become what they say is a malpractice shield, right? When MIT had a suicide, like every university does, you know, the Supreme Court brief wrote about the Columbia as the reasonable standard with the 1% high risk answers. So that barrier has really been broken down. It's kind of minimum standard of care. And the unprecedented science really supports that, you know, 600 studies, 50 predictive. There's a new meta-analysis coming out, Mann et al. And BMJ, you know, predicting death by suicide, which has never happened in the field before, and suicidal behaviors. So that's all I wanted to share today. And I was right at 5 minutes.
Thank you so much. We appreciate it, Dr. Posner. With that, I will transition it over to our next segment. Or actually, we're checking out South Dakota because we have them as our featured presenter. If you're from the other states and you would like to do a featured presentation, please let us know so that we can get you checked off in the presentation map. So states, very important. I'm going to transition this over to my colleague, Daniel Heron from Vibrant and Stephanie Pasternak from NAMI to give us an update on states.
Great. Thanks, Laura. And I'll get us started before I hand it off to Steph. Just wanted to share some important state updates. Many state legislatures have been in session this year, and most of them have been wrapping up as the year goes on, but a few key legislation updates to share. First, want to flag that in Illinois, they have just passed their 988 fee bill. It's a little bit different than other states' fee bills because it takes the existing interstate telecommunications tax, which is based percentage based of the total revenue. So it was already at 7%. They increased it to 8.65% with that 1.65% increase going to 988 as the new statewide 988 surcharge. So really exciting to see Illinois becoming, I believe, the 12th state to create a 988 telecom fee bill. Also flagging that in Florida, we saw a bill that added 988 as an essential crisis service under the Department of Children and Families. It also removed barriers for MAT programs. And it also created a new annual appropriation of 1.7 million. That's increasing Florida's annual reoccurring appropriations for 988 up to a total of 4.3 million altogether. So really excited to see that sustainable funding continuing in Florida. And then just a couple more in Wisconsin. We saw that they saw a general revenue or a general fund revenue appropriation of 7 million for the 988 contact centers. That's the first time that Wisconsin has passed general fund appropriation. So we're really excited to see that. And there's hope that that might become a recurring appropriation. And then finally, just wanted to flag that in Hawaii, they signed a bill that expands crisis intervention and diversion services to include at least 2 sites. Currently, there was 1 site, but it's expanded to 2 sites on the island of Oahu. so that there will be greater access to services in areas with disproportionate number of individuals with mental health disorders. And I believe that that is taking effect later this year. With that, I will pass it over to Steph from NAMI for a few more updates.
Just wanted to recap a couple fee proposals. Folks probably knew that we were watching. We're in New Jersey and New Hampshire. So starting in New Jersey, the governor there wanted to see a 988 telecommunications fee put into the state budget. Unfortunately, that was not picked up by the legislature, but this is something advocates are hoping to raise again in the state after the fall elections. And then in New Hampshire, there was also a fee proposal. I will say this made very significant headway. It actually passed the Senate in the Senate's version of the state budget. However, in the last few weeks, when the New Hampshire House and the New Hampshire Senate got together to reconcile their differing versions of the state budget, unfortunately, the fee did not make it into that final agreement. So I will say, while this didn't cross the finish line, it was very encouraging to see how much support this received in the legislature. And I know NAMI New Hampshire and all the partners there are going to keep fighting for this during the next budget cycle. And then in terms of new legislation, jumping over to Massachusetts, there is a new fee bill there of, I think it says 75 cents per line per month. It's our understanding that the language in the bill might be reworked, hasn't been scheduled for a hearing yet, but we will certainly let folks know. And I'll just end also to say that we also have a new resource out in addition to our poll. We've released a new edition of our 988 state legislation brief, recapping kind of legislation trends, highlights of state bills from last year. I'll put it in the chat. Just a great resource to look at if you kind of want to look at some examples, some models that you might want to bring forward in your state.
Awesome. Thank you, Daniel, and thank you, Stephanie. Lots happening in the States and much more progress than we saw 5 years ago. So with that, I'll turn it over to Arrow Foster for our Peer Central segment.
Hello, Laura. Good to see you again. And also, I wanted to say, grant me some grace today. There was so much information in this. My hands were flying on the keyboard, jotting down notes to what to talk about. It's been wonderful. And thanks to Jordan and Janet and the team for that great presentation. As a peer specialist, it's really encouraging to see how much intention and cultural respect has gone into the planning. And it's clear that you're not just building services, but you're building trust. That's the real heart of any effective crisis system, because it brings that level of care that truly feels like care. One thing that stood out for me is how deeply you engage the tribal leaders, elders, farming and ranching communities, voices shaping that 988 messaging. That was awesome. Too often systems create that outreach from the outside looking in, but you're co-creating it with the community. And co-creation is exactly the kind of partnership that can really reduce fear and stigma around asking for help. I'm also, grateful to hear how peers are being integrated into the call center. In many rural and tribal communities, trust can't be built overnight. So peers bring that authenticity and cultural understanding that can make the difference between somebody accepting help and turning that help away. So the creative solutions around telehealth hubs and local transportation also really stood out, specifically that direct line access on the tablets. That was awesome to see. In peer support, we see how practical barriers like distance or internet access can completely derail someone's journey toward stability. So it's encouraging to hear how you're all working to remove those barriers. I'm excited about all the innovations and South Dakota's proactive responses to the challenges. I just want to share a few reflections from the peer lens about potential challenges that we have seen as I've been around the country and that may appear as other communities embrace these innovations and begin to institute them in other areas. One piece is workforce capacity cannot be stressed enough. building that workforce capacity before rolling everything out is so important, and we often see that that's a major hiccup for people. It's vital also to keep planning on how to support those peer workers, not just through pay, but with that peer-powered supervision, ongoing training, self-care resources, and things like that. So people still may prefer face-to-face connections also, especially during crisis. So balancing that technology with the human connection, which it sounds like South Dakota is doing a great job with, needs to be that ongoing conversation. So this is what I heard today really reflects what we talk about when we say systems should be person-centered and community-driven. The focus on cultural respect, local partnerships, creative problem solving gives hope that these solutions are sticking. I encourage everyone to keep those peers at the table because our lived experience can help spot those gaps that may not show up in that data. So thanks again for sharing all the work and all the information and all the comments. They were awesome to watch, and for the commitment to making sure no community is left behind. I'm really looking forward to seeing how these efforts continue to unfold. Really great. Back to you, Laura.
Thanks for that perspective, Arrow. I'm now going to turn it over to Stephanie Hepburn for Crisis Talk.
Thank you, Laura. So I'm going to bring on Emma Burris. She's the person who wrote today's guest essay op-ed. She's a senior at Barnard College, Columbia University. She's researching crisis mental health care with a particular interest in adolescent populations. Hi, Emma. Are you able to hear me?
So do you want me to talk a little bit about my article?
Yes, I wanted you to touch on the article, but also dive into your study and what the objective is.
Great. So I'll attach the article in the comment right here. So yeah, I'm a senior at Barnard in New York, and I'm studying the experiences of former adolescent inpatients in psychiatric facilities. And this will actually be one of the very first studies to study the actual lived experience of people who were in psychiatric facilities as adolescents. And it'll be the very first study to evaluate that in the context of Jennifer Freyd's concept of institutional betrayal. And I can put the link in the chat as well to the study if anyone wants to take a look. It would be great if anyone could share it with their networks if they have people who would potentially meet the eligibility criteria. And yeah, I encourage everyone to take a look at the article. It's we're already experiencing a mental health crisis in the country, and adolescents are especially being left behind. So yeah, something I'm really passionate about, and also I'm happy to connect with anybody. I'll put my email in the chat as well.
Emma, could you talk a little bit, when you talk about institutional betrayal, can you talk a little bit about what that looks like in the context of adolescents and inpatient hospitalization, and why this is important to study in particular?
Yeah, so institutional betrayal is essentially a concept of like when someone puts trust in an institution and depends on that to support them, and the institution betrays that trust. And it is studied in a lot of different scenarios, and the mental health environment is one of them. So I'm working also out of a lab at Washington University in St. Louis that works with behavioral mental health care, and they were the first lab to study institutional betrayal in the context of psychiatric care. And so the question was, how is it applied to adolescents, right?
Right.
Yeah, so adolescents are also especially vulnerable to institutional betrayal because they have higher expectations for care than maybe adults do. Adolescents, especially, for the most part, they're living within a home environment. They have parents or guardians. They're not used to living independently. And so you can imagine how scary it is to be like committed to a psychiatric facility. You're a minor, you don't understand what's going on. It is like a really, really vulnerable situation. So it's something that I feel is being very overlooked in the mental health environment today.
And if you could talk just a little bit about your survey. There are two components. There's a survey component, and then afterwards you'll do some one-on-one interviews. Could you talk a little bit about what you'll be looking at in the survey?
Yeah, so I essentially am studying different aspects of the psychiatric hospital experience. For example, like built environment, like the psychiatric like inpatient care, like expectations for care, like trust in crisis care after, getting out of the hospital, also like mental health diagnoses. And it really is trying to cover like a lot of demographics, background demographics, experiences in the facility, and then how that has impacted mental health after being discharged. And so there's the first survey, and then if anyone's interested after filling out the survey, I'm opening up the opportunity to participate in an interview where I will just ask more questions about the specific experience of hospitalization to get at the nuances of care. And so it'll be a mixed methods analysis. I definitely want to get at the qualitative component as well because patient-centered care is so important.
Well, thank you, Emma. Thanks for doing this work, and I'll pass it back to you, Laura.
Thank you, Stephanie, and thank you, Emma, for joining us and sharing about your work. So important. I love that concept of institutional betrayal. Really important for studies to go there. So thank you for doing that. So let's look forward to next week, next Wednesday at noon Eastern. We will have episode 227, and it will feature Dr. Jennifer Lockman as our featured presenter on Thrive, brief recovery-focused interventions, very important. And then the week after that, we're back with our Fireside Chat series, Preparing for a Career in Crisis Services. Dr. Jonathan Singer, again, very important work as we think about the crisis workforce and making sure that folks have a place to stay in their career. So super excited. And then in 2 weeks, well, that was the 2 weeks. So thank you for joining us, and I hope everyone has a lovely day.